We'll just do some quick intros. So I'm Dan Byrne. I'm the Public Health Lead for Drugs, Alcohol and Tobacco at Leeds City Council, and I'm joined by my colleague Rachel. Do you want to introduce yourself, Rach?
Hi everybody, good afternoon. My name is Rachel Dukes. I'm an advanced health improvement specialist working with Dan in public health with a remit on drugs and alcohol.
And we've also got Colin from our team helping us with the IT and the slides. Colin, do you want to introduce yourself?
Yeah, sure. Thank you. Hello everyone, thanks for coming today. My name's Colin. I'm a graduate apprenticeship helping to support Leeds Public Health, and today I'll be supporting this webinar from an ICT point of view to hopefully avoid any technical issues. Enjoy.
Brilliant, thank you for that, Colin. And just to let everyone know, this session's being recorded this hour, if everyone's okay with that. So what we're going to talk about today, then, this afternoon, is responding to drug and alcohol use during COVID-19. This fun year we've been having. We're going to talk about a few things. We're going to talk about remote working in drug and alcohol services, the Everyone In initiative, and other opportunities that's brought. We're going to be talking about drug and alcohol campaigns, and also specific projects that have been happening this year, namely the Leeds Liver project. So Colin, could you give me the first slide, please? So in terms of remote working, this is something you'll all be familiar with. In fact, it's something we're doing right now. Forward Leeds is our drug and alcohol service in Leeds. It's the city's integrated drug and alcohol treatment service for adults and young people. And to give you an idea of what it's like, there's approximately 3,500 service users in treatment at any one time. And the service operates from 3 hubs across the city, plus a recovery hub. And everything was going fine at the beginning of the year, and then March hit, didn't it? And the government made various announcements around COVID-19 that forced services to close their doors. Now, as a drug and alcohol service, we couldn't just obviously stop drug and alcohol treatment. But due to the fact that back then, if colleagues remember, we had no policies or procedures how to deal with COVID-19. It was very new. We didn't have COVID safe buildings or PPE, if anyone remembers the fight for PPE back then. It meant that Forward Leeds as a service had to go remote, which meant all service users at the service working on online platforms such as Zoom, Teams, Skype, and also over the phone. And when this happened, we worried, to be honest, because everything we knew up until that point was that drug and alcohol treatment was about face-to-face working, whether that's one-to-one work, such as with a key worker, or in groups, so treatment groups, recovery groups. And we worried that it would have a negative impact on treatment. It could have been a catalyst for people dropping out of treatment and relapsing, but we had to make that move because we couldn't have the buildings open. Colin, could you give me the next slide, please? But we were quite surprised because when we started working this way, we started to hear some interesting and surprising benefits of remote working. For example, the service having greater contact with service users because they could contact them over the phone or online relatively easily. In addition, the service was reporting that they were assessing more people and faster. Now, obviously, that's not the most important thing in the world in drug and alcohol treatment, but it was when service users started reporting that they were having a higher quality of assessments. And when asked, albeit this is anecdotally, service users were saying that in the absence of being able to read facial expressions, particularly when their intervention was audio only, they found that key workers were having to ask more and more in-depth questions. We also had service users saying that because of this, the engagement was better, that they had better rapport and more meaningful engagement with the service. And from a service perspective as well, the service was finding that people were turning up to more appointments. As you can imagine, in the drugs and alcohol treatment world, we often have people who don't turn up to appointments, but more people were turning up as scheduled. And when asked, people were saying, well, remote working's removed the barriers that previously existed, such as travelling to a building, the time it takes, maybe money, bus fares, etc., or anxiety in getting there. We even found that the services were picking up people new to treatment, individuals who'd never previously engaged with the service, particularly those who we already knew to be complex, were starting to engage. And a big surprise for me was we even had people reporting in group work that some service users were preferring to work remotely. And when asked, we had service users telling us things like, well, I have anxiety and I don't like people looking at me, but I can go into a remote group work and I can turn my camera off so people can't see me. And in addition, they felt people were opening up more as they were in their homes and in touch often, and even saying that they felt closer even though they were more physically apart. Could I have the next slide, please, Colin? But of course, it doesn't work for everyone. There are drawbacks, such as, for example, what I call the COVID laboratory settings. So just because remote working works during this time, this unique time, does it work when we're back in a normal world, whatever that looks like? I mean, I remember service users at the start saying that they were grateful that the service remote working and was able to do that. But at the same time, in a world where there's the option to have face-to-face interventions, then would that still be something you prefer? In addition, I think time is an important factor here. We've seen people who were very into remote working at the beginning, but who've become fatigued over time. Even those who really liked it have started to say that they want some more face-to-face work. At the same time, I think we also have to consider inequality and digital exclusion. Not everyone has a great laptop, a great internet connection, or any laptop or any internet connection. And you will all have experienced in your work times when you've dropped out of Skype meetings. This can negatively affect people who don't have those things, and our population would be heavily impacted by that. In addition, it's quite important in our world to be able to see people. Someone may be telling you they're fine, but if they, for want of a better way of putting it, look skeleton thin and have two black eyes, then clearly they're not. And these are things that can be hidden when remote working. Also, the impact on staff working from home. You will have probably heard stories of staff finding it difficult to work from home. And if you're in your home and you're listening to traumatic stories about drug and alcohol use and maybe domestic violence, the differentiation between that and not having that kind of separation between home and the office can be quite difficult for people. Also, the changing seasons. Is remote working going to be something that's as easy to do during these times up until the end of winter than it was in the summer? I also think we have to be cautious. Remote working could be an opportunity to cut costs, especially when it comes to commissioning and commissioning of services. Remote working, to put it bluntly, is cheaper, and maybe you don't need those extra rooms or that extra building. I think it's really important that remote working comes from the service user and not the service. Can we have the next slide, please, Colin? So back in the summer, then the NIHR put out a call for any COVID-19 public health initiatives that could do with evaluating things that were happening during COVID-19 that could benefit from an evaluation to inform a post-COVID-19 world. And we put in a proposal for evaluation to look at remote working in drug and alcohol services. This was a collaboration between us, Forward Leeds, York Street Health Practice, Joanna Project and Basis. And Joanna and Basis came along because we had stories from them saying, we've got a lot of our service users who are working really well with your drug and alcohol services, but the thing that you're not considering here is that we're preparing them to do that, and we're giving them the space to do that, and we're also giving them the means to do that, such as mobile phones. So together with York Street Health Practice as well, who specialise in delivering GP services to GPs, put in a bid, and we were successful with that proposal, along with 3 other public health initiatives in England. At which point we were paired up with the University of Hertfordshire, and we are now involved with them for a 1-year study, which is going to go until the end of next year, looking at how we can use remote working in the future in our service delivery. My kind of feeling on this is that I don't think that services will ever operate as they did pre-COVID-19, but they also won't operate as they did when COVID-19 hit at the very beginning. I see it more as perhaps in the future a blended approach where if you want to remote work because that's better for you, then you do remote working. If you want to do face-to-face interventions, similarly do that. If you want a combination of the two, then you can do that. Or maybe you want to switch depending on how it fits your life. So you may prefer face-to-face working, but then you might go away for 2 or 3 weeks outside of the city, at which point you might want to switch to remote working for those 2 or 3 weeks and come back to it. So we are now, we've got all our anecdotal evidence. We're now doing a full 1-year study on it, being done by a university, a proper robust study. And if anyone wants to have any updates on that, you can contact me directly about that. So that's everything I want to say about remote working. I'll pass you over to Rachel now, who's going to talk about the Everyone In and other opportunities we've had during this year. Over to you, Rach.
Thank you. Right, next slide, please. Okie doke. So this is a slide with a little bit of a quote from the letter we received, or local authorities received, back in March from the MP Luke Hall. So our strategy must be to bring in those on the streets to protect their health and stop wider transmission, particularly in hotspots and in those assessment centres and shelters that are unable to comply with social distancing. So Luke Hall is the Minister for Homelessness and Local Government. So the first thing to say in terms of rough sleeping and homelessness is that there is a difference between them. So for people that are homeless, they may have access to a permanent home, but it may not be safe, suitable or accessible, or for a whole raft of other reasons. They don't feel able to be there and therefore prefer or need to stay with friends, family perhaps, or be on the sofa, or be resident in other accommodation like a refuge or a hostel. Whereas rough sleepers are choosing or feel that they have no other choice, and perhaps don't have any other choice as well, to have anywhere to stay at all. And some people prefer, even though there's a lot of risk with being on the street, prefer to live on the street. And this can be obviously for sometimes weeks, sometimes months, but unfortunately even years. So again, you might hear the term people living a street-based lifestyle, to sort of capture people that have chosen, unfortunately, to be on the street and feel that that's the safest place for them to be. So other groups as well, which we feel needed to be included in terms of our response as a local authority, are other groups where you could describe or define them as being homeless, or even rough sleeping as well. So that includes people without recourse to public funds, destitute asylum seekers, nomadic or transient groups such as travellers, gypsies, Roma communities, people fleeing domestic abuse, and female sex workers. And homelessness unfortunately affects children and whole families as well. So when this letter arrived, we were already scaling up plans for provision of what we were going to do in terms of providing suitable accommodation for those on the street, for those rough sleepers, in the event of people becoming ill with the virus, but also what we could do to prevent people contracting the virus. Next slide, please. So this is a bit of an overview to make the connection here back with drugs and alcohol. And this is taken from Public Health England's Guidance Health Matters document around rough sleeping, which was produced earlier on this year actually. So people who sleep rough experience some of the most severe health inequalities and report much poorer health than the general population. Many have co-occurring mental ill health and substance misuse needs, physical health needs, and many have experienced significant trauma in their lives. So as you can see there, we've got some really stark statistics. 42% of people sleeping rough had alcohol misuse needs, 41% for drug misuse, a very high correlation between mental health support needs within the rough sleeping community. And also important to say that 20% of people didn't have alcohol, drugs or mental health support needs. So we do also need to catch that it isn't everybody. So in terms of obviously accessing services, sometimes for this group of people, it can be very hard for them to access services. So again, we needed to find a way to get people off the streets quickly, to encourage and provide the support for people to distance, to adhere to government guidelines, to have testing if needed, and if positive, to obviously isolate fully. So we also were looking to set up a provision for people, a specific provision for people with symptoms as well. Next slide, please. So the first thing we did was to reorientate commission services. So these are services that the local authority funds. And because obviously from the slide before you could see the variety of needs that people may have, and therefore we set up a wide variety of temporary accommodation. So we actually had 11 sites at one point during the initial peak back in the spring. So to be able to effectively meet the needs of these groups, we sort of use the specialist workers that we have within the services we commission to be able to support them. So these services have workers that are specifically trained around things like being trauma informed, about supporting vulnerable women, including sex workers, those fleeing domestic violence, drug and alcohol specialists. So we brought in our colleagues within Forward Leeds to help here, providing general and specialist support around whether it's access to housing or benefits or whatever it was as well. So again, we had 11 sites initially, and we had around 200 people in temporary accommodation in Leeds. The second thing we did was to make sure that we had a female-only emergency accommodation site. And you would think that this would be fairly obvious, or at least I thought this would be fairly obvious, but when we've been on various webinars, national meetings and so on this last year, it's become clear that Leeds has actually been quite unique in this, and we've been held up as an example of good practice nationally. And this has been recognised by some of the real biggies in terms of agencies fighting against homelessness and rough sleeping, places like Homeless Link, St Mungo's in London, and Standing Together, which is a domestic violence and abuse organisation. It's one thing that we felt was really important, is to make sure that we had separate provision for women. Another thing we did, which was sort of it applies to the first and second point on the slides, is that everybody that went into the emergency accommodation got an individualised care and move on plan. So that includes anybody. So we had specialist provision, for example, in one area, in one place, which was aimed at destitute asylum seekers and those without recourse to public funds. To female sex workers, to people fleeing domestic violence, to people that have been on the streets. Every single one of those groups received an individual care and move on plan, which was something that we were proud of. And even when it came to those without recourse to public funds, services were really excellent in looking at where individual cases were up to, and if there was anything that could be done in terms of looking at asylum claims and move on plans, and what is needed to support those that didn't have recourse to public funds. The hygiene and distraction pack provision I'll come on to in a second, but I think the other thing that has really underpinned everything has been something called the Silver Street Support Improvement Board. There is a bronze one of these and also a gold one of these. Most of our work fed into the silver level and the gold level. But by having this group, which is chaired by Safer Leeds, over the last year it's mushroomed to be the place to coordinate and plan all the provision in the city around vulnerable groups and rough sleepers and homeless people in particular. So it very quickly mushroomed in terms of representation for more key services. So we had places like Leeds Housing Options, we had Public Health, we had the Street Support Team, we had Bevan Healthcare, which is linked to York Street Health Practice, which Dan mentioned before. And this group was meeting weekly at one point, just due to the scale and the pace of things, and sometimes the bronze group would then meet daily. But this has proved really successful and has really helped us to be able to respond quickly and effectively when we've had new challenges come up. The other thing as well is we've been very involved in public health, in supporting Public Health England in developing what's been called joint working agreements for underserved groups. So these are documents that have been written. So one's been around underserved groups, which includes refugees, asylum seekers, homeless people, rough sleepers, etc. And there's also been another one written, which is vulnerable populations in residential settings. So this one also includes people that use hostels or refugees, etc. So these documents have been put together to help plan and support local authorities and other partners in dealing with COVID and looking at what we need to do in terms of prevention, what we need to do if there is an outbreak, what we need to do in terms of locking down an outbreak, reducing further transmission. So next slide, please. Okay, so I mentioned the distraction packs before. So excuse my little pictures from Google here. I was trying to make the slide look really exciting, trying to show the range of things of what this included. Because you might think something like a distraction pack, well, firstly, what is it? But also, that doesn't sound like something that perhaps is really needed. Well, what became clear was that actually these have been vital. And I got in contact with a community activist initially back in March who was fundraising on her own to provide support for people that were being moved into the temporary accommodation. She had some experience of working with rough sleepers, and she was putting together these things called packs, which very quickly became known as distraction packs. So I was able to get some extra funding to add to the money that she'd already fundraised. So we had at that point about £9,500 to look at putting together actual packs of the things that people need to support them when they're in temporary accommodation. So these were things like additional toiletries and sanitary products, cleaning packs, obviously with everything with COVID, so we wanted to make sure that people had access to laundry detergent, antibacterial spray or wipes, hand sanitizer, etc. Underwear, very often, unfortunately, people turn up literally with the clothes on their backs and that's it. So other items of clothing. And activity packs, again, you know, thinking if that was me and I've been put into emergency accommodation with literally as what I have to stand up in. Firstly, I've never been probably in a hotel room for many years, but what would I need to help keep me active mentally as well? So we had things like puzzle books, pens, stamps, and over time the NHS got involved and started producing distraction packs nationally, so we've been distributing those as well. So between March and the end of June, 1,000 of these packs went out across the city. And we had a really positive feedback. So on the back of that, we then were successful as a local authority to get an allocation from one of the grants that had been released from central government, and £50,000 had been identified to support rough sleepers. So on the strength of the initial work I've done on the distraction packs with partners, that entire budget line has gone to extend the provision. So in partnership with the Silver Street Support Improvement Board, which I mentioned earlier, we've been able to allocate the whole of that funding around the following themes. So providing essential items to help people that have just arrived in emergency accommodation, to enable those housed in that accommodation to stay engaged and to follow guidance, to provide essential items to those new or returning to the street in terms of preventing infection. So this is things like masks, hand sanitizer, torches, rape alarms, etc. And also sometimes mobile phones, which Dan mentioned earlier. Providing essential items for those that have secured new housing. So we're trying to cover the range here from people that have arrived onto the street, to those going into the accommodation, to those being housed after being within the emergency accommodation, and having a loop back to those that are back on the street, because there are a small cohort that have returned to the street. And also a line around helping everybody within that group to isolate effectively. So we're able to include more things this time. So we could do things like train tickets, warm clothing, food items, the new tenancy packs, we've called them, for those people that have moved on into new accommodation. Very often there's been a gap in terms of what the housing authority could provide. And quite often people really needed some practical stuff in terms of bedding, or stuff for the kitchen, just to help them get started. And again, we thought this was really important in terms of encouraging people to stay engaged with services, which hopefully would mean that they're less likely to return back onto the street. Next slide, please. As a result of the rough sleeper work, we have found there's been some other opportunities, and quite a large strand of this has been around hepatitis C. Hepatitis C, as you probably know, is a bloodborne virus, and it does have links with vulnerable groups such as rough sleepers and the homeless due to passing on through sharing of equipment. So we were able to use the opportunity of having the accommodation sites to be able to take hepatitis C screening directly to clients. So normally there is a clinic delivered by Leeds Teaching Hospital Trust through York Street Health Practice, and this time we were able to use the team from LTHT, the team from Bevan Healthcare, which is the one that's linked to York Street Health Practice, with the Hepatitis C Trust as well. And we're able to use a mobile bus used by Bevan, which is those top two photos. And we were able, or they were able, to actually get some funding. I think this came from the Hepatitis C Trust, to give people incentives to come forward for screening. So again, they provided either shop vouchers, drinks, also sort of care packages of toiletries and things like that. So this was delivered in the summer, and 6 clinics were run, a combination of which, some of which were in hotel sites, some of which were directly on the street, and 61 people were tested for Hep C, and 33 of those were not already known to services. And 20 of those people have started or restarted hepatitis C treatment as well. This is absolutely huge, because hepatitis C is now really able to be treated successfully, and this is a key message we've been trying to get out, which we'll come on to in a minute. But with one of the nurses involved, Tracy, has said that the COVID-19 pandemic has led to a unique set of circumstances which enabled the Leeds Viral Hepatitis team to take their outreach service directly to vulnerable and homeless people in Leeds. This has only been made possible through multi-agency collaboration between the Trust, Hepatitis C Trust and Bevan Healthcare. So the number of people tested, that 61 number at the start, is actually greater than the number of people the service can normally access or encourage to come forward for screening. So the approach has really worked, and it's something that we're really pleased to see. Next slide, please. This is going to come out, I don't know how this looks everybody's end, but it's just a little screenshot I've taken from recent awards. So the approach of doing just what I've said around hepatitis C screening has received quite a lot of national attention, and one of the workers from Bevan Healthcare was nominated in one of the NHS staff award schemes as well in terms of his approach. So I just wanted to highlight that. Next slide, Colin, thank you. So also what we've had running at the same time, and Dan's going to go on to campaigns in a minute, but we have also developed our own hepatitis C campaign in Leeds in partnership with Forward Leeds, and the outreach work that was done around rough sleepers, we're able to use some of our leaflets. So these are some of the infographics that we've used in terms of making people aware that they might not know that they've got hepatitis C infection, and also just to myth bust really in terms of hepatitis C, how it was, certainly in terms of treatment, and how it is now. There's a link there for more information from the Forward Leeds website, which you might find useful. Next slide, please. Right, and just before Colin launches this, we heard in February of this year that the Coalition for Global Hepatitis Elimination, which is part of the Task Force for Global Health, was launching its first annual hepatitis elimination video contest. So we thought, let's enter. We've produced the Don't Live in Doubt leaflet. Let's look at putting together a film. And the film has also been shown in Millennium Square and other places in the city. So we entered that same video into this competition, and in May we found out that we came joint second. So we were joint second with entries from Uganda and New Zealand. So it was a real sort of global success, which we were absolutely delighted about. So this is where we're going to test the technology now, because Colin is going to play the video for you. Fingers crossed.
A few years ago, I went to the doctors and I sat down and I said, I don't know what's wrong, but something is. And I had some blood tests and my platelet count was low and my liver count came back high. I had some further tests and a few weeks later I had a letter saying you have hepatitis C.
I found out that I first had it when I had a blood test. I was devastated, really. It hit me a lot. It's hard to explain, but I just felt like things were coming to an end. The treatment that I went through was so easy compared to what I'd heard about the last treatment that they used to do, because the last treatment I'd seen was a guy doing injections and it made him really ill. But this treatment now is so easy.
I remember sitting in a room with the doctor who said, normally I'd be telling you to go home and make your arrangements, but I'm going to get you on this new treatment that is nothing like the one you've just had. And he was true to his word. Compared to the old treatment, this one was a walk in the park. 12 weeks, popping a few pills. I could carry on working, I had my life back.
I am so glad I did this treatment and got tested, and I've done it now, and that's it. I'm over the moon with it.
Thanks, Colin. Okay, next slide. I think at this point oh no, it is still me. I can't remember when Dan's coming back in. We just wanted to also share with you a hot off the press item, which has literally just been delivered. It's actually been delivered by the Public Health Resource Centre this week and by the printers. Obviously, news of the vaccine is fantastic. But in the meantime, we are obviously still conscious we've got a active coronavirus still in circulation, and how to pass on key messages for the next however long it's going to be until the vaccination program's rolled out fully. So we've produced a rough sleeper COVID-19 leaflet. However, we do think it's transferable perhaps for other groups, not least because we've wanted to make sure it's as accessible as possible, so we've tried not to use too much wording. The key thing here is that we've used a format which we used a couple of years ago with a spice campaign. You might have heard of spice. It's a substance which has been associated with the rough sleeping community, and it was a campaign we were involved in trying to increase awareness of what spice is and isn't. There's a lot of sort of myths around it being linked to being a legal high, when actually it's man-made and chemical and nasty. So that leaflet was put together, and it was done on A6 in A6 sort of format, so nice and small, so it could fit into a pocket. And we also had it printed on durable card, so it would last longer. And that campaign proved to be successful, and there was a lot of interest in what we put together. So for this particular one, we wanted to use exactly the same. So we've used the same approach, the same template, and again, it's been printed on card, more durable well, it's a paper still, but it's more durable than paper, and it's got a more of a shiny coating, so it lasts for longer if it gets wet. And again, it's A6, so it fits in people's pockets. I've had 4,000 of these printed in the first run, and up to date as of this morning, I think I've shifted about 3,200 of them so far. So they've been sent to all the on-street commission services that we have in the city. So this includes partners like Change Grow Live, Forward Leeds, Bevan Healthcare, Beacon, which is a intensive supported housing provider, Leeds Housing Options, the council's mental health and homelessness team, the street support team, St George's Crypt, Joanna, Basis, St Anne's Resource Centre, etc. So this is to hopefully be used either on the street or to give to people if they're being placed in temporary accommodation, or for those clients that are in move-on accommodation, perhaps in a tenancy, which might be communal or might be separate, and it could be displayed on notice boards, etc. as well. Next slide. Thank you. Okay, I'm going to hand back to Dan at this point. Thank you.
Thanks for that, Rach. Yeah, so I said we're going to talk about campaigns. So drug and alcohol campaigns have also been impacted by COVID-19 during this time. So in Leeds, we have what's known as SMAP. SMAP is the Drug and Alcohol Social Marketing Planning Group. This is a group that is a collaboration between Leeds City Council and Forward Leeds, our integrated drug and alcohol service. It's a group that I chair. Rachel's on this group as well. And pre-COVID, we developed what you might call like packages of content when we had our campaigns. So I picked the campaign that Rachel's just shown up again, the Don't Live in Doubt campaign. And as you can see, in the top there in the middle, that's a trifold leaflet that we had made, which was sent to services across the city, such as GP services. In fact, I actually saw the leaflet in my own GP practice in Yeadham when I happened to just be in the waiting room one day. So that went to all services like that. Either side of that, those are posters, and again developed to be put up in places like GP practices. And then Rachel also showed the video there, that 2-minute video, kind of digital content, and it was kind of a mixed package. But because of COVID-19, we found ourselves in a situation where we couldn't do what we normally do. So we weren't able to do leaflets because we weren't able to give them out because of COVID-19. It seemed pointless making posters to be put up in settings that were closed because of COVID-19. No one was going to see them. So what we decided to do then was to move our drug and alcohol campaigns exclusively digital. And we've been doing that ever since March when COVID-19 hit, which includes our drug and alcohol harm reduction campaign that we've been running this year. So the campaign would normally be combinations of things like leaflets, posters and digital, but everything went digital. And our campaign this year was made up of 11 animations. And these animations were kind of short messages around reducing harm for drug and alcohol use. And they were 20 seconds long so that they could be shared on social media, such as places like Twitter, Facebook, Instagram. And what we're going to do now is, again, try to test the technology. We've got about 5 of these lined up. They're only 20 seconds long. So I'm going to pass over to Colin, and he's going to play some of these.
Hopefully you've all had time to watch the first animation. I'm going to go to the next animation now, if that's okay. And I should have said, don't worry, there is no sound on these animations either, so don't be alarmed if you can't hear any sound. Thank you. Now, this will be the final website animation to be done today. Please enjoy.
Brilliant, thanks for that, Colin. And apologies for how clunky this presentation is. Obviously, if we were in a room all together, we'd be playing these on the screen. But we're doing the best we can, given that the three of us are in different parts of Leeds right now. So another drawback or benefit maybe of remote working for that list we talked about earlier, depending on how you look at things, I suppose. So the animations there, short, snappy, about 20 seconds long, about home drinking, about not making up for lost time, and also about going out, having a game plan, keeping you cool, what we call leave the mix into the DJ when it comes to drugs and alcohol. As I mentioned, these have been promoted on social media such as Twitter, Facebook, Instagram. We've also currently got some of them being played on the big screen in Millennium Square so that they can be seen by people who are in the nighttime economy, when the nighttime economy is open, of course, and we've got those playing until the end of the year. So in addition to that, then this year's Alcohol Awareness Week 2020 was a little different. The focus this year, every year it has a theme, and this year's theme was alcohol and mental health. So again, taking a similar approach, everything was digital. So we had a couple of short videos. One was a clinician from Forward Leeds talking about the link between alcohol and mental health, as well as another video we have made a couple of minutes long as well about things to do instead of drinking. We had an online quiz around alcohol, and again it's to mental health, keeping with the themes, as well as staff from Forward Leeds doing virtual meetings with various mental health organisations across the city, training for professionals, as well as the fact we officially launched Drink Coach in Leeds, which is a digital app. So we launched a digital alcohol app digitally, if that makes sense. Could I have the next slide, please, Colin? So finally, what I'm going to talk about, could I have the next slide, Colin? That's it. That's the one. Thank you. Is a project that we've been doing pre-COVID-19 that got impacted by COVID-19. As I think it's a good illustration of its impact. So going back now to when I kind of started in post back in April 2018. When I first came into post, I met a consultant called Dr. Richard Parker at Jimmy's, and he talked to me all about how he wanted to eradicate alcohol-related liver disease. And how you do this is you get a rather expensive machine called a fibre scanner. They cost about 100 grand, and they're a bit like an ultrasound, but instead of finding a baby, they find specific scarring on the liver that indicates early-stage alcohol-related liver disease. And he had this project called the Community Hepatology Project, and the Community Hepatology Project was a project that he was running, but he had very limited equipment. He had one of these machines, a portable version of this machine that he could take to GP practices, but it was old, borrowed, and he was trying to get funding for a new one, and it also had limited reach because it was just the one machine. So this was something that interested me. I'd never heard of these machines before, and in November 2018, Public Health England launched its Alcohol Capital Fund, which was a £6 million fund, which it wanted local authorities to bid for. And the purpose was to help local authorities prioritise alcohol treatment, invest in equipment and facilities, and to ensure that treatment expertise could be enhanced to much better meet the needs of those with alcohol issues. So we put together a proposal. Next slide, please, Colin. And we were successful. It was a proposal to purchase two portable fibre scanner machines, one to be used in the Forward Leeds hubs to identify people with alcohol-related liver disease to be referred into the hospital, and also one for the hospital in reach team, the Forward Leeds Hospital in reach team, in order to both find people who needed treatment for alcohol-related liver disease, but also who could be referred into Forward Leeds if needs be. 23 projects across the country, so 23 local authorities got funding. 9 of those were to purchase fibre scanner machines. So along with us, Brent, Hillingdon, Oxford, Bath, Berkshire, Manchester, Cheshire, Merseyside and Nottingham all got funded. And that was when we gave birth to the Leeds Liver Project. So we had a little bit of a title change there, a rebranding, if you like, because we were able now to not only have a fibre scanner in GP practices, but also in an InReach team in hospital and in Forward Leeds. And also during that time, Dr. Parker was successful in getting his own funding to replace the old borrowed machine that he had, which was a bit like a Spectrum, as I put up in the previous slide. Good for its age, but not so good now. So we now had 3 shiny new fibre scanner machines, one in primary care, one in secondary care, and one in community care. And we were all ready to start our projects. Next slide, please, Colin. Which we did in January of this year. And the project started fine. Everything was going great. We had people being scanned in all 3 settings in those targeted GP practices, in the hospital InReach team, out on the wards, and also in the Forward Leeds hub. In addition to that, the money kind of invited more money. So because of the project, Forward Leeds dedicated 1 member of staff 1 day a week to the project, as well as training others. And we also had the same in the hospital, a dedicated member of staff working 1 day a week on the project to help that out. And then, of course, we got to March 2020 again, and government announcements around Covid-19. And this kind of dropped a bit of a bomb on the Leeds Liver Project, because in terms of GP practices, they stopped doing face-to-face working, as people will probably no doubt know, and moved to remote working. We've already talked at the Forward Leeds hubs, stopped face-to-face working and moved remotely. The hospital became very COVID-focused back then, obviously the way it needed to be. And we also had a British Liver Trust event cancelled in June. That was going to happen. They were going to bring their buses up to Leeds, and we were going to have a whole event, but that couldn't happen, all because of COVID-19. At which point, because of the nature of fibre scanning, where you have to obviously get close to people and scan them, nothing could happen in any of those environments. Only a few months after starting the project, until next slide, please, Colin. Until July 2020, when the settings started to reopen again. So Forward Leeds hubs reopened, the hospital were able to do fibre scanning again, but both with restrictions. So although the settings reopened, the project had to change, because unlike previously, we now have policies and procedures around COVID-19. We had COVID safe buildings, we had the PPE, just like we talked about earlier, enabling us to get this project back off the ground. But as I mentioned, in a different way. So in Forward Leeds, although it reopened in July, there were caps on the numbers of people allowed in the buildings. That's caps on both staff and service users, and also and restrictions on them moving between the buildings. In addition, the project got impacted by remote working of staff, and also staff having to self-isolate themselves because of COVID-19, and also service users being able to go to the hubs for appointment-only appointments, and also the impact of remote working on them and not wanting to go into the hubs because of the situation. In addition, in the hospitals, it was very dependent on the COVID-19 situation in Leeds and hospital admissions, and the wider impact on staff resources and the number of kind of COVID and COVID-free wards. GP practices continue to work remotely now, and in terms of those in GP practices, we're now taking referrals for people to be fibre scanned in the hospital, so a GP can refer someone to the hospital, but obviously we get a bit of a drop off there because not everyone gets to that appointment. So the fibre scanner project, the Leeds Liver Project, is a good example, a project that started in January, got paused in March because of COVID, and now has come back since July in a different form. We're working with the restrictions, and hopefully, going into next year, if the restrictions start to come off, we'll have more freedom around that. In addition, just to link us back to our campaigns and the nest mapping, we are currently now planning the Healthy Leeds Livers campaign. So this is a campaign that we're currently developing. Again, it's digital because we have to operate in this world still. So that's going to be a campaign with a couple of videos. I mentioned Dr. Richard Parker earlier. He's going to star in one of those videos about having a healthy liver, why a liver is important, and how to maintain liver health. We'll have another video with a service user, and we're going to do various infographics, animations, similar to the ones you saw earlier with the drug and alcohol campaign that we ran, the harm reduction campaign during the summer, that we're going to be able to put out on social media. And when we put those out, we will also be able to then put with them on, for example, tweets, etc., or websites, up-to-date information on where you can get FibroScanned and the restrictions as they stand on that day, which can obviously will change over time. So that's everything I want to say on that, and that's the end of our presentation. So thanks, Rachel, for your input on this. Thank you, Colin, for helping us out. We hope people have enjoyed that. Apologies for the clunkiness of the videos. As I say, if we were all in a room together, we'd be able to put it on a big screen. And finally, questions which don't have to be Christmas related, as that picture suggests. So if you would like to ask a question, I think the best way to do it is probably to just highlight that in the messages, and we'll kind of pick you out, and Colin will be able to then turn your mic on. Is that okay, Colin?
Yeah, that's fine.
Thank you, everybody. Any questions?
Actually, just in case anybody has got a question, but for whatever reason they haven't got access to write in the text box, I'm just going to unmute everybody's mic, so feel free to just, declare your name and then just ask your question orally.
Oh, here we go. Okay. We've got Margaret McKee.
Yeah, come on, Margaret.
Yeah. I work late evenings, and very often we get a lot of rough sleepers and homelessness coming up to us and asking for blankets or food and money. And this is around the Old Beck and Hunslet area, and it's always between 6 and 8:30. That's the hours when we're working. Is there can you hear me?
Yeah.
The question.
Where do we when they're asking us these questions, where do we actually refer them to? Do you know, because they're often asking, because they're often sleeping rough down in the bushes down at the bottom end.
If it's something practical, you can speak. The best place would be Leeds Housing Options, and probably Navinda Clayton, because she's also managing all the rollout of the distraction packs in some of the accommodation sites. But also, she and her contacts could link people up with services as well. The other option is CGL. I'd speak to them, Change, Grow, Live. They're based at Duncan House at the bottom of Briggate, and they have an outreach team. So you could also give them the heads up in terms of where you're being approached and where people are, and they could come out and have a chat with people and see what they might need. So I'd probably pursue those two in the first instance. So any others you'd suggest, Dan?
No, but in addition to that, if they will also know other people to contact, and they will have so the services, obviously they know each other, they know how to contact each other, they've often got each other's mobiles, and they're able to so yes, I would say start there. There are also emergency lines that get put out from Safer Leeds, but start with if CGL and, as you say, housing options, depending on their need, what they want to do.
Yeah, because there's one of them in particular is not from this country, and he speaks very little English.
Right. Okay. Okay. Again, you could look at contact through either somewhere like Lassen or Paphras or Simon on the Streets. It would depend where he's from and the language needs he's got. But any of those three organisations, certainly Simon on the Streets, again, have got a very large sort of economic migrant strand. So they've got speakers of community languages, as do Paphras and Lassen. But it depends on where he's from. But they'll be able to assist.
Right, okay, thank you.
Okay,
yeah,
no
CGL also have people who can speak different languages,
yes,
but also access to people who can translators as well. So it would be, they would be able to sort that out depending on the need and obviously the language.
And if you need any contacts, Margaret, you can always email us. You're internal, aren't you? You can always drop us a line and we can pass it on.
All right, great, because it's every week we're seeing them now. It's about 3 or 4 of them.
Okay, fine. Right, okay. Well, by all means, come back to us if you need any more contacts and details and stuff. All right.
Thank you. Well, thank you very much.
Thanks. Anyone else have a question? Oh, someone's typing.
Someone's typing. Joanne Thornton. Oh,
All
thank
right.
you very much.
I like those questions.
Yeah, they're lovely.
We'll do a final call for questions. I don't think anyone else is typing at the moment. Are all the mics live, Colin?
Yes, all the microphones are open. If you can't get access to the chat box, feel free just to ask any question you have verbally. Verbally, even, sorry.
We've stunned everybody into silence. I hope we've
Okay.
got the pace okay. We were trying to cover quite a lot of information there. So,
Well, if there are no more questions, thank you to everyone for coming this afternoon, and enjoy your Christmas and have a great New Year. Thanks, everyone.
thanks everybody. Take care. Bye bye.
Thank you. Bye.
Bye.